will be discussing the physical diagnosis of the thorax and lungs, as well as the breast and the axilla. So this is two chapters in your Bates. So as always, try to read the book and use this lecture as a guide. Okay, but your main source will always be the chapters in the book. Okay, so let's start. So, I'm sorry if you haven't had dinner yet, no? Ako din, pareho But you can listen, no? While having a meal or so. But just continue to take note of the discussion, okay? So, for the thorax and lungs, the following are the objectives. Of course, I want you to know the anatomy of the thorax and lungs, proper history and physical examination, normal findings on physical examination, and the abnormal findings and the diseases that it's composed of or naturally leading to. So, for the anatomy and physiology, now it's always important to go back to the anatomy of the area of the body that you are about to discuss. No? So this is the chest area, and here are the landmarks. I'm sure you already have memorized that, no, during your previous year. So hopefully you still recall these areas because they will be of good use to you again when you discuss physical diagnosis. So when look to locate the findings of the chest, there are actually um, actually assigned to numbers, no, between the ribs. So the ribs and the spaces have their corresponding numbers. So it's usually the second rib that we sorry about that. It's usually the second rib that we are able to palpate when we do our physical examination. Let me just go back one slide. So these are the number of ribs and intercostal spaces, and note that the number of the intercostal space between two ribs is the same number as the rib above it. Okay, so let's say, for example, the second rib. So below it is the second intercostal space, and as follows down the line. So this is the third rib and the third intercostal space. Directly adjacent to the sternal angle or the angle of Louis is your second rib. So you can try to palpate that now, no? Try to palpate your angle of Louis and move either to your right or to your left, no? If you're doing it now, then you're able to palpate the second rib. Okay, and below that is your second intercostal space. Okay. So for the costal cartilages of the first seven ribs, they articulate with the sternum. So these costal cartilages from ribs 1 to 7 articulate from the sternum, while your cartilages of the eighth, ninth, and 10th ribs articulate with the costal cartilages above it. Okay, so the 11th and 12th ribs are already called your floating ribs because it has no anterior attachments, as you can see in this image here. Well, the cartilaginous tip of the 11th rib is usually felt laterally, and the 12th rib may be felt posteriorly. So for the 12th rib, the starting point for counting rib, it's usually the starting point for counting ribs and intercostal spaces on the posterior aspect of the chest, and provides an alternative to the anterior approach. While is another useful bony landmark rather. It usually lies at the level of the seventh rib or interspace. While your spinous processes of the vertebrae here are also considered as useful landmarks. When the neck is flexed forward, the most protruding process is usually the vertebra of C7. Okay, so C7 here. If you protrude your neck or flex it forward. Now, that's usually what you can feel. So you can try to do it also right now. So you can palpate the vertebra or the spinous process of your C7. So if two processes are equally prominent, then it's most likely your C7 and your T1. So other special landmarks would include in the second intercostal space, it's usually where we insert the needle when a patient suffers from a tension pneumothorax. So the immediate intervention is to do needling, and it's usually inserted into the second intercostal space. While your fourth intercostal space is where usually the TCVS or thoracic surgeons insert their chest tube. T4, on the other hand, is the lower margin of an endotracheal tube on a chest x-ray. No? So when we do chest x-ray, usually we measure the length of the tube, no? Or how far away it is from the carina, and the radiologist would also use T4 as a marker, as an appropriate level of the ET tube. Neurovascular structures run along the inferior margin of each rib. No? So it's under the rib. So needles and tubes should be placed just at the superior rib margin. So example, when we do thoracentesis, we palpate, we usually palpate the rib and then the space below it, no? So it's always better that you insert the needle closest to the superior rib margin rather than the inferior margin, especially if the space is narrow, so as to avoid the neurovascular structures that run along the inferior margin of each rib. For T7 to T8 intercostal space, it's a landmark for a thoracentesis with needle insertion immediately superior to the eighth rib. So that's what I was discussing earlier. So for the lines of the chest, no, there are important lines or margins that we also consider. So the mid-sternal and vertebral lines are easily demarcated because of the area of the structures that it represents. No? So mid-sternal line, as well as your vertebral line at the back. So the mid-clavicular line, it's the line that drops vertically from the midpoint of the clavicle. No, so the midpoint of the clavicle and the line that runs along below it. So to find it, you have to identify accurately the both ends of the clavicle, so you know that it's already the middle part. For your anterior and posterior axillary lines, as seen in this image, anterior and posterior axillary lines. So these are the lines from the anterior and posterior axillary folds, the muscle masses that border the axilla. The axillary line drops from the apex of the axilla down. While there, as mentioned earlier, the vertebral line is it overlies the spinous process of the vertebrae, while the scapular line drops from the inferior angle of the scapula, as seen here. So for the lungs, fissures, and its lobes, so the apex of each lung rises approximately 2 to 4 centimeters above the inner third of the clavicle, while the lower border of the lung crosses the sixth rib at the mid-clavicular line and the eighth rib at the mid-axillary line. For the posterior aspect, the lower border of the lung would lie at about the T10, no, spinous process. On inspiration, it's expected to descend in the chest cavity during contraction and descent of the diaphragm. For the lungs, fissures, and lobes, each lung is divided roughly in half by an oblique major fissure, as you can see here. So here and this one on the left. So the fissure may be approximated by a string that runs from the T3 spinous process obliquely down and around the chest to the sixth rib at the midclavicular line. So there's a difference between the right and the left lung, because the right lung is divided by the horizontal or the minor fissure, and it's divided into the upper, middle, and lower lobes. So right upper, right middle, and right lower lobe. So the oblique fissure and the minor fissure of the right lung, and this is the left oblique fissure. So three lobes on the right, two lobes only on the left. Each lung receives deoxygenated blood from its pulmonary artery, which is then oxygenated. It returns as oxygenated blood as it returns from each lung to the left atrium via the pulmonary veins. So locations on the chest. So as it's very the name itself would describe the area it's supposed to be pointing to. So supraclavicular above the clavicles, infraclavicular below, interscapular between the scapula and the bases of the lungs are the lowermost portions, and the others are the upper, middle, and lower lung fields. So the trachea and the major bronchi. So breath sounds over the trachea and the bronchi have a harsher quality than those over the denser lung parenchyma. So the right main bronchus is wider, shorter, and more vertical than the left main bronchus and directly enters the hilum of the lung. So this is the right main bronchus and compare it with the left one. Well, the left main bronchus would extend inferolaterally from below the aortic arch and anterior to the esophagus and thoracic aorta and then enters the lung hilum. So each main bronchus then divides into lobar and then into segmental bronchi and bronchioles, terminating into the pulmonary alveoli. And this is the gas exchange area of the lungs. So aspiration pneumonia is more common in the right, middle, and lower lobe because the right main bronchus is more vertical, so it tends to enter there. No, the particles that are aspirated by the patient tends to enter into the right, middle, and lower lobe more than the left side. So for the pleura, these are two. There are two continuous pleural surfaces or serous membranes that separate the lungs from the chest wall. Your visceral pleural line green here in this image is the covering that out is the covering that surrounds the outer surface of the lungs, and it's said to lack sensory nerves. No, so it doesn't really cause pain when it is punctured. But the parietal pleura lines the pleural cavity, so the blue line here along the inner rib cage and upper surface of the diaphragm, and it is richly innervated by the intercostal and phrenic nerve. So when we do thoracentesis, of course, because we are accessing the space between the parietal and the visceral pleura, no? So there is some pain when the needle is inserted, and that is why we also give anesthesia to this area. So pleural space is a space between the visceral and parietal pleura and contains serous pleural fluid. Pleural effusions is what we call the accumulation of fluid within the pleural space. So it could be transudative from cases of heart failure, cirrhosis, and nephrotic syndrome, but it can also be exudative in nature, especially in infectious cases, but also in malignancy, in embolism, in tuberculosis, and even in pancreatitis. So the irritation of the parietal pleura produces pleuritic pain with deep inspiration in cases of viral pleurisy, pneumonia, pulmonary embolism, pericarditis, and collagen vascular diseases. So for breathing, you check we know that the diaphragm is the principal muscle of inspiration. So during inspiration, the diaphragm is expected to contract, descend in the chest, and expand the thoracic cavity, compressing in turn the abdominal contents and pushing out the abdominal wall. So the muscles in the ribcage, especially your scalenes, is responsible for expanding the thorax, while your parasternal intercostal muscles or your parasternals cross obliquely from the sternum to the ribs. They also support breathing. So on expiration, your chest wall and your lungs will recoil and the diaphragm relaxes and rises passively. And the abdominal muscles will also assist in your expiration. The irritation of your, so this is from the previous one. So, common concerning symptoms when it comes to the respiratory system is, of course, chest pain, dyspnea, wheezing, cough, hemoptysis, daytime sleepiness, and snoring or disordered sleep. So for chest pain, you ask for any discomfort or unpleasant feeling in the chest. So point to the location where the pain is elicited. Watch for any gestures that the patient describes and elicit all seven attributes of chest pain. So your lung tissue, as we've mentioned earlier, has no pain fibers. It's only your pleural tissue. Now your parietal pleura. So pain mostly arises from the parietal pleura, and the examples that we've mentioned earlier can actually cause pain. But there are some extrapulmonary sources of chest pain, and these are your GERD and even anxiety. So a clenched fist over the sternum would actually describe angina pectoris, which is common in heart attack or myocardial infarction. A finger pointing to a tender spot on the chest wall, so a more localized area of pain, would usually be secondary to a musculoskeletal pain, while a hand moving from from the neck to the epigastrum would signal a probable reflux of acid. No, so it's described as heartburn and usually common in GERD patients. So these are the sources of pain and the related causes. So some of which were already discussed earlier, no, but try to review this table as well as you go through the pages in your baits. So shortness of breath or dyspnea and wheezing is a painless but uncomfortable awareness of breathing that is inappropriate to the level of exertion. So you ask this, have you ever had any difficulty in breathing? So you have to find out if it occurs at rest or with exertion and how much exertion would produce the onset of the pain. You ask for the number of steps or flights of stairs that the patient is able to climb before having dyspnea, and about carrying bags of groceries, vacuuming, making the bed, or different activities that would elicit this symptom. So, also ask whether the shortness of breath is already affecting the patient's lifestyle and daily activities, and the timing and setting, or any associated symptoms or relieving or aggravating factors. On the other hand, your wheezing is a musical respiratory sound that may be audible to the patients and to others. So it occurs in partial airway obstruction from secretions, tissue inflammation, which is common in asthma or from a foreign body, but we also hear this in COPD patients. So, cough, one of the most common symptoms that the patient would seek health care consultation would be, no, so it's actually a reflex response to stimuli that irritate receptors in the larynx or in the trachea or large bronchi. So the stimuli would include your mucus, pus, blood, allergens, dust, foreign bodies, or even extremely hot or cold air. So, other causes would be inflammation of the respiratory mucosa, pneumonia, pulmonary edema, compression of the bronchi or bronchioles from a tumor or peribronchial lymph nodes. But your cough may actually also be cardiovascular in origin, especially in heart failure. It could even be gastric in origin, no, in GERD patients. So when we say acute cough, it's usually less than 3 weeks, subacute lasting 3 to 8 weeks, while your chronic is more than 8 weeks. No? So there are different etiologies for each duration of the cough. Of course, infection is most common in acute uh, cough, while subacute, it could still be post-infectious cough, acid reflux, sinusitis, and asthmatic patients. For chronic, we also have asthma, postnasal drip, GERD, chronic bronchitis, and bronchiectasis. So for mucoid sputum, it's usually translucent white or gray and is usually seen in viral infections or even cystic fibrosis. But purulent or yellow to green sputum usually accompanies bacterial pneumonia. So you also have to ask for any smell, no foul smelling sputum may be attributed to anaerobic lung abscess and also a thick tenacious sputum in cystic fibrosis. So for you also have to ask, especially for quantification, how much the patient, how many the patient could cough up in 24 hours. Is it a teaspoon, tablespoon, half cup, cupful? So large volumes of your purulent sputum are present in cases of bronchiectasis and lung abscess. So helpful symptoms would be fever, productive cough in pneumonia, wheezing in asthma, chest pain, dyspnea, and orthopnea in acute coronary syndromes or cardiac etiologies. Hemoptysis is blood coughed up from the lower respiratory tract, so it may vary from being blood streaked to really having frank blood. So you have to quantify the volume of the blood that is produced, and there are several causes. In the Philippines, one of the most common would be your tuberculosis, no? But other causes would be bronchitis, malignancy is a common cause, cystic fibrosis, and less commonly for bronchiectasis, mitral stenosis, good pasture syndrome, and even Wegener granulomatosis. Massive hemoptysis is defined as more than 200 centimeters, not cubic centimeters. This amount of hemoptysis may already be life threatening. It could cause severe anemia that already would alter the cardiovascular um, status of the patient. So, first, for hemoptysis, you have to confirm the source of bleeding. Is it blood or blood streaked material in the nose, mouth, pharynx, or gastrointestinal tract that may be mislabeled as your hemoptysis? So, if it was vomited, then it's most likely melena or hematemesis rather than hemoptysis. For blood originating in the stomach, it's usually said to be darker than the blood from the respiratory tract, and it's mixed with food particles. Other symptoms that you have to take note of is your daytime sleepiness, snoring, or disordered sleep. No? Because these could be hallmarks of your obstructive sleep apnea, which may be common in obesity, malocclusion, hypertension, heart failure, AF, stroke, and in diabetic patients. So for the examination, so for techniques in the posterior thorax and lungs, we do it while the patient is sitting, but for the anterior thorax or lungs, we do it while the patient is supine. So begin with inspection, palpation, followed by percussion, and then auscultation. So IPPA. So, assess first for any signs of respiratory distress. So, for tachypnea or more than 25 breaths per minute. Inspect for the patient's color if the patient is already cyanotic or with pallor, and listen for audible signs of breathing like any audible wheezes. Inspect the neck also if there is any use of accessory muscles, and during expiration, try to check if there's contraction of the abdominal muscles. So, for inspection, standing in a midline position behind the patient, note the shape of the chest and how it moves, including any deformities or asymmetry in chest expansion or muscle retraction of the intercostal spaces. So, you also have to check for any impaired movement on one side or both sides of the chest. So asymmetric expansion could be secondary to large pleural effusions, and retraction of the chest could be secondary to asthma, COPD, or upper airway obstruction, while the unilateral impairment or lagging could be from pleural diseases like asbestosis or silicosis, or seen in phrenic nerve damage or trauma. So for palpation, as you palpate, focus on the areas of tenderness, bruising, and check for respiratory expansion and fremitus. So this is the areas that you also have to palpate, not as labeled. 1, 2, 3, and 4. You have to palpate these areas simultaneously because you have to compare the left side from the right side. So palpate both lungs for tactile fremitus. This refers to the vibrations that is transmitted through the bronchopulmonary tree to the chest wall as the patient is speaking. So it's usually symmetric on both sides. So to detect fremitus, you use the ball. No, that's the bony part of the palm at the base of your fingers. You can try to palpate it here. So, and or you may use the ulnar surface of your hand. No, so ask the patient to repeat the words 99 or 111. So use both hands to palpate and compare the symmetric area. So 99 for each number. So 99, 99 as you move along from 1 down the line. So, intercostal tenderness can develop over inflamed pleura or costal cartilage tenderness in costochondritis. Well, tenderness, bruising, and bony step offs are common over a fractured rib. So, your fremitus is usually decreased or absent when the voice is higher pitched or soft, when the transmission of vibrations from the larynx to the surface of the chest is impeded by 1, a thick chest wall, 2, an obstructed bronchus, 3, COPD, or 4, pleural effusion, fibrosis, pneumothorax, or an infiltrating tumor. So for percussion, as you can see here, this is the intercostal space in between the ribs. No, so one of the most important techniques of physical examination of the chest is your percussion because it helps you establish whether um, the cause of the decrease in the percussion or the dullness would be it could differentiate from air, so pneumothorax, or fluid pleural effusion or consolidation like in pneumonia or mass. So hyperextend the middle finger of your left hand, and this is known as your pleximeter finger. Then you position your right forearm close to the surface of the hand. No, so here, m- as you the middle finger should be partially flexed, relaxed, and poised to strike. So, with a quick, sharp, but relaxed wrist motion, strike the pleximeter of the right middle finger, called the plexor finger, and strike using the tip of the plexor. So, just this area here, not the finger pad. The striking finger should be almost at right angles to the pleximeter. So you withdraw your striking finger quickly to avoid damping the vibrations, and the movement is at the wrist. It's directed, brisk, relaxed, and slightly bouncy. It's quite difficult not to really um, master the art of percussion. So you just have to keep trying. You can actually do it on yourselves, no, on the anterior chest, not just to have a feel of how it will sound like. So this is the manner or the ladder pattern that you should follow. So 1, 1, then 2. It's like a snake pattern, right? Ladder pattern. So 4, 4, 5, 5, 6, 7, then 6, 7. Dullness replaces resonance when fluid or solid tissue replaces air containing lung or occupies the pleural space beneath your percussing fingers. So this could occur, dullness could occur in cases of lobar pneumonia, pleural effusion, hemothorax, empyema, fibrous tissue, or a tumor. And dullness makes pneumonia and pleural effusion 3 to 4 times more likely. So generalized hyperresonance, on the other hand, is common for hyperinflated lungs of COPD or asthma, while unilateral hyperresonance would suggest a large pneumothorax or an air-filled bulla. So we also can do in the posterior chest, you can also check for diaphragmatic excursion. I think that's also discussed in your gastrointestinal. It's discussed more thoroughly. Um, So for percussion notes, so these are the different notes na, and their characteristics. I just want you to go through that on your own as you review the book. So let's proceed to auscultation. So before we begin auscultation, you ask the patient to cough once or twice to clear the mild atelectasis or airway mucus that could produce actually extra sound. So the most important examination technique for assessing airflow through the bronchial tree would involve one, listening to the sounds generated by breathing, so normal breathing, inhale, exhale, and two, listening for any adventitious added sounds, and three, if abnormalities are heard, listening to the sounds of the patient's spoken or whispered voice as they are transmitted through the chest wall. So listen to breath sounds using the diaphragm of your stethoscope. Always place it directly on the skin because clothing can alter the characteristics. No? Use the ladder pattern suggested for percussion as you move from one side to the other, comparing symmetric areas of the lungs. And note that the intensity of the breath sounds, which reflects the airflow at the mouth, may vary from one area to another. So the breath sounds are usually louder in the lower posterior lungs, and you have to also listen for the pitch, intensity, and duration of the inspiratory and expiratory sounds. So vesicular breath sounds, normal breath sounds, it's soft and low pitch. It's heard throughout inspiration, continues without pause through expiration, and then fades away about one third of the way through expiration. While your bronchovesicular is an inspiratory and expiratory sound about equal in length at times separated by an interval. So detecting the differences in pitch and intensity is often easier what if you listen to the expiratory breath sound. While your bronchial breath sounds, these are louder, harsher, and higher in pitch with a short silence between inspiratory and expiratory sounds. And your expiratory sounds would last longer than inspiratory. And your tracheal sounds are loud, harsh sounds heard over the trachea and the neck. So these are the comparisons no between those different characteristic breath sounds. So I'll give you a link later on where you can listen to these breath sounds on your own. No? So you can really hear it because even if I play it might be not so audible. No? So just want you to listen to it on your own so that you can really differentiate once you already have a patient that you can auscultate. So transmitted voice sounds, if you hear abnormally located bronchovesicular or bronchial breath sounds, then you have to assess the transmitted voice sounds using three techniques. So listen with your diaphragm, listen to the symmetric areas of the chest wall, especially if you're suspecting pneumonia or pleural effusion. So egophony, you ask the patient to say E, and you will normally hear a muffled long E sound. For bronchophony, ask the patient to say 99, and normally the sounds transmitted through the chest wall are muffled and indistinct, and louder voice sounds are noted. While for whispered pectoriloquy, you ask the patient to whisper 99 or 1, 2, 3. So through whisper 99 or 1, 2, 3. And the whispered voice is normally heard faintly and indistinctly, if at all. So for auscultation, you also have to assess. Now, if you hear crackles, especially that do not clear after coughing, then you have to check or identify the characteristics. Now, mainly the loudness, the number, the timing, the location, the persistence of the pattern, or any change after a cough or in the change of position. So for the anterior chest, you also have to do inspection, palpation, percussion, and auscultation. So these are the locations that commonly look utilize when doing anterior chest wall examination. So you can also percuss for liver dullness and gastric tympany. So usually this is also discussed in your gastrointestinal system. So for recording of the physical examination of the thorax and lungs, here is how a normal exam would uh, be reported. So thorax is symmetric with good expansion, lungs are resonant, breath sounds vesicular, no crackles, wheezes, or rhonchi. Diaphragm descends 4 cm bilaterally. And the next one would be an abnormal breath sound. So thoracic symmetric with moderate kyphosis and increased anteroposterior diameter, decreased expansion, lungs are hyperresonant, distant breath sounds with delayed expiratory phase, fremitus, decrease, no bronchophony, egophony, or whispered pectorality. Diaphragms descend 2 cm bilaterally. Although it's quite different in real practice, no? So it's not this detailed, no, but it's better if you can really do a detailed reporting of the chest lung study. So my video won't play, so you can actually scan this QR code, no, or take a picture of it, because this would lead you to a for the link to this video where you can check the guide on how to do a complete chest physical exam. I'm trying to double check if it's still a correct link. Yeah, so it's still a correct link. No? So this guide has been used as practice for OSCE. So try to take a photo or screenshot this link. And this one is your link, or you can use this link for practice or for listening to the different types of breath sounds. Okay. Anyway, I can give you a copy of of these slides, no, so you also have a copy of the link. So, as always, no, you have to listen to your patient because he is already telling you the diagnosis. If you just do your PE and your history and physical examination, well, then half the battle is already won when it comes to diagnosing the patient. So I'll proceed to the next one, okay? The next chapter. Kindly wait a moment. Do you have any questions so far for that first chapter? Because if none, I'll proceed to the next one, if that's okay with everyone.
None so far po, no?
Okay, thank you. Can you guys see my screen?
Yes po, Doc.
Okay. It's moving naman, no? Yeah.
Yes, opo, Doc.
So
Moving
here
naman.
are the objectives, no, more or less the same with the chest and lungs. Of course, you need to know the anatomy, proper history and physical examination, and demonstration of the physical examination of the breast. So for anatomy and physiology, the female breast lies against the anterior thoracic wall and extends from the clavicle and second rib down to the sixth rib from the sternum across to the mid axillary line. It overlies the following muscles, no? So you have your pectoralis major, you have for the inferior part, you have your serratus anterior, and it's divided into four quadrants. But the fifth area is usually considered as the axillary tail of the breast tissue, or the tail of Spence, and it extends laterally across the anterior axillary fold. So So, your breast is a hormonally sensitive tissue and it's responsive to changes of the monthly cycle and aging. For glandular tissue, it also consists of milk secreting tubuloalveolar glands and ductules, which forms 15 to 20 septated lobes radiating around the nipple. It also has a fibrous connective tissue, which provides its structural support in the form of fibrous bands or suspensory ligaments known as your Cooper's ligaments, and it's connected to both the skin and the underlying fascia. It's also composed of adipose tissue surrounding the breast in the superficial and peripheral areas. So the surface of the areola are composed of sebaceous glands, sweat glands, and accessory areolar glands. During pregnancy, these sebaceous glands would produce an oily secretion that would serve as a protective lubricant for the areola and nipple during lactation. So your smooth muscles in the nipple and areola would contract to express milk from the ductal system during breastfeeding. It's also very rich in sensory innervation, and this is used to trigger milk letdown following neurohormonal stimulation from the sucking infant. So the adult breast may often be soft, but it could also feel granular, nodular, or lumpy. Okay, so the females here would attest to that. No? So sometimes there is an uneven texture in normal physiologic nodularity. It's bilateral, it occurs throughout the breast, and the nodularity may increase before menses. So it's a time when the breasts are often enlarged and become tender or even painful. So for the male breast, it consists of a small nipple and areola alveole overlying a thin disc of underdeveloped breast tissue consisting primarily of ducts, and the ductal branching and development of the lobules are very minimal as compared to the females. So we also have benign breast enlargement, no, which is known as gynecomastia, and the proliferation of palpable glandular tissue is known as pseudogynecomastia. So these are abnormalities in the male breast. The causes of gynecomastia would be one, increased estrogen. So sometimes this is actually self-induced, no? So the intake of pills is also a common practice, no? So decreased testosterone and medication side effects. So, for the lymphatics of the breast tissue, most lymphatic vessels of the breast drain into the axillary lymph nodes. The central nodes, these are most likely to be palpable, lie along the chest wall, high in the axilla, and midway between the anterior and posterior axillary folds. Sorry about that. So the three other groups of lymph nodes drain into the central nodes and are seldom palpable. So these are the other three. So your pectoral nodes, subscapular nodes, and your lateral nodes. So for the health history, common concerning system when it comes to the breast would be breast lumps or masses, breast discomfort or pain, and nipple discharge. 50% of women have palpable lumps or nodularities because there's a premenstrual enlargement and tenderness of the breast. So it's usually common. But you have to identify the precise location, the duration of its presence, and any change in size or variation within the menstrual cycle, and ask if there has been any change in contour, dimpling, swelling, or puckering of the skin over the breast. So, breast pain or mastalgia. So, the most common breast symptom prompting office visit would be your breast pain or mastalgia. So, breast pain alone without mass, breast pain alone for a while. Breast pain alone without mass is not considered a sign of breast cancer or a risk factor. So you have to determine if the pain is diffuse or focal, or and if there is cyclic or non-cyclic changes to these. So you have to ask for any discharge from the nipples when it occurs. So does the discharge appear only after compression of the nipple, or is it spontaneous? No, so bilateral or unilateral, or is there any physiologic changes that you have observed? So for abnormalities for the breast lump or mass, the lumps may be physiologic or pathologic, ranging from cysts and fibroadenomas to breast cancer. So it's always warranted to do a clinical breast examination. So breast discomfort or pain is more likely to merit diagnostic image. So, sorry, let me just. Okay. Okay, so let's just proceed to the techniques of examination. So for an inspection, initially it requires full exposure of the chest later in the examination. So you always have to cover one breast while you are palpating the other. Inspect the breast and nipples with the patient in the sitting position and disrobe to the waist. Inspection of skin changes, symmetry, contours, retraction in the four views should be done. So arms at the side, arms over the head, arms pressed against the hip and leaning forward. So in your book, there's actually an image no, on how to do these steps properly. So arms at the side, you have to take note of the appearance of the skin, including the color, any thickening of the skin or unusually prominent pores. This would usually this is usually secondary to lymphatic obstruction. No? So we see this in breast cancer patients. They usually have these changes, no? Especially if left untreated. The size and symmetry of the breast, you have to take note of that. The contour of the breast, look for any masses, dimpling, or flattening, and compare one side with the other. So for the nipples, you have to check for the size and the shape as well. So arms at the sides, still, you have to check if the nipple is inverted, points inward, depressed below the areolar surface. So it may be enveloped by folds or areolar skin, but can be moved from its sulcus. So it's usually a normal variant of no clinical consequence, except for possible difficulty when breastfeeding. So arms over the head. So hands pressed against the hips, leaning forward. It brings out dimpling or retraction that may otherwise, sorry about that, that may otherwise be invisible. So you have to ask her to raise her arm over the head. So press her hands against her hip to contract the pectoral muscles and inspect for the breast contour. So you can see the following figures here. So if the breasts are large or pendulous, have the patient stand and lean forward, supported by the back of the chair or the examiner's hand. So abnormalities check for redness because this might suggest local infection or inflammatory carcinoma. Changes that are suggestive of breast cancer would include one, thickening and prominent pores, flattening of the normally convex breast, asymmetry due to change in the nipple direction, a nipple pulled inward, tethered by underlying ducts, breast dimpling or retraction, inward dimpling of the skin during muscle contraction. So, but this can also be accompanied by benign conditions like post-traumatic fat necrosis or a mammary duct ectasia. So we also have what we call the Paget disease of the breast. So this is when eczematous changes with rash, scaling, or ulceration on the nipple extends to the areola, and it's usually associated with an underlying ductal or lobar carcinoma. So for palpation, this is best performed when breast tissue is flattened, so the patient should be supine. So palpate the rectangular area extending from the clavicle to the inframammary fold or brow line, and from the mid-sternal line to the posterior axillary line, as seen in the image there. So it would only take about 3 minutes for each breast. So use the pads of your second, third, and fourth fingers, keeping the fingers slightly flexed. You do it in a vertical strip pattern because it's the best validated technique for detecting breast masses. So, as seen here, no, usually palpate in small concentric circles, applying only light, medium, and deep pressure at each examining point. So, press more firmly to reach the deeper tissues of a large breast and examine the entire breast, including the periphery, tail, and axilla, because sometimes the masses are already there near the axilla. No? So it's very important that you palpate that area as well. So for the lateral portion of the breast, roll onto the opposite hip, placing the hand on the forehead but keeping the shoulders pressed against the bed or examining table. So begin the palpation in the axilla, moving in a straight line down to the brow line. Move the fingers medially and palpate same, no, in a vertical strip pattern. So continue in vertical overlapping strips until you reach the nipple and then reposition to flatten the medial portion of the breast. So next would be on the medial. So from the axilla to the lateral portion of the breast, now to the medial portion. So more or less it's the same pattern, no, that we use. So you have to examine carefully for consistency of the tissues because they vary widely, and some would have physiologic nodularities before menses, and inframammary ridge. Now, these are transverse ridges of compressed tissue along the lower margin of the breast, and it may sometimes be mistaken for a tumor. Tenderness may also occur prior to menses, and nodules or a dominant mass or lump or mass that is different from or larger than the rest of the breast tissue may be pathologic when evaluated by a mammogram, an aspiration, needle aspiration of the mass, or a biopsy. So assess for the characteristics of the nodules by getting the following characteristics: no, location, the size, the shape, the consistency, the delimitation, the tenderness, the mobility of those nodules. So try to move the nodule while the patient relaxes her arm and then while she presses against her hip, and palpate each nipple, noting its elasticity. So nodules in the tail of the breast or in the tail of Spence may sometimes be mistaken as an enlarged axillary lymph node. But it can actually be a start of malignancy or a mass. So for mammary duct ectasia, you may have tender cords, but sometimes painful. It's a painful condition causing dilated ducts with surrounding inflammation and associated masses. So hard, irregular, poorly circumscribed nodules that are fixed to the skin or underlying tissue would be a strong it would strongly suggest the presence of a possible cancer. So, thickening of the nipple and loss of elasticity would also suggest an underlying malignancy. Nipple discharge, especially if there's a history of discharge, you have to try to determine the origin by compressing the areola with your index finger placed in a radial position around the nipple. Watch for any discharge expressed from any of the duct openings on the nipple surface and note the color, consistency, and quantity of any discharge and the exact location where it appears. So for milky discharge unrelated to a prior pregnancy and lactation, it's called your non-purpural galactorrhea, and causes of which would be hyperthyroidism, pituitary prolactinoma, and dopamine antagonists, including psychotropics and phenothiazides. So for the male breast, you also have to inspect the nipple and areola for nodules, swelling, and ulceration. Breast cancer can also occur in males, no? So you have to also carefully do this. So palpate the areola and breast tissue for nodules, and the breast, if the breast appears enlarged or more than 2 cm, you have to distinguish between soft fatty enlargement of obesity, like pseudogynecomastia, or the beginning of a benign firm disc of glandular enlargement or your gynecomastia. So breast tissue in gynecomastia is often tender. So this condition arises from an imbalance of estrogen and androgens, sometimes could be drug related. So it's not a risk factor for male breast cancer. So if you have a hard, irregular, eccentric, or ulcerating, painless dominant mass, this could suggest breast cancer. So the axilla may also be examined with the patient lying down, and sitting position is preferable. But the sitting position is preferable. So inspection, you have to inspect the skin, noting for rash or infection. No? So sometimes patients would have hidradenitis suppurativa. It is a sweat gland infection from a follicular occlusion. And unusual pigmentation could be secondary to acanthosis nigricans, nor a deeply pigmented, velvety axillary skin that is associated with diabetes, obesity, PCOS, malignant paraneoplastic disorders. So this could be how a hydradenitis suppurativa could look like, and this is your acanthosis nigricans. So for the palpation, so ask the patient to relax with the left arm down and warn the patient that the examination may be uncomfortable because your axilla is also a sensitive area, right? So support the patient's left wrist or hand with your left hand, cup together the fingers on your right hand, and reach as high as you can to the apex of the axilla. So place your fingers directly behind your pectoral muscles, pointing toward the mid clavicle. Then you have to press your fingers toward the chest wall and slide them downward, trying to palpate the central nodes against the chest wall. So the central nodes are most likely to be palpable, but one or more soft, small, less than 1 cm non-tender nodes are frequently felt in this area. So the same goes for the right. No, so you have to check for the pectoral nodes, the lateral nodes, subscapular nodes, and infraclavicular and supraclavicular nodes. So if you have a node that is large, no, or more than 1 to 2 cm and firm or hard, matted together or fixed to the skin or underlying tissue, then this could already suggest malignancy. So you also have special techniques, no, especially for those with mastectomy or breast augmentation procedures. So for inspection, you have to check for the scar and the axilla for any masses, unusual nodularities, or any signs of infection or inflammation because your lymphedema may be present in the axilla and upper arm from lymph drainage interrupted by the previous surgery. So for palpation, you have to gently palpate along the scar as well. No, still using the same circular motion with 2 or 3 fingers, and you pay special attention to the upper, outer quadrant, and axilla to note for any enlarged lymph nodes. So it's very important that you do a breast self-examination, no? So especially for high-risk patients with family history of breast cancer or those with persistent nodules or masses. So this a high proportion of breast masses are detected by women examining their own breast. So for screening, the BSC has not shown to reduce breast cancer mortality, but it does promote health awareness and earlier reporting of changes or masses, which may reduce the unnecessary testing and biopsies compared to your monthly self examination. So, your BSE is best timed 5 to 7 days after menses when your hormonal stimulation is low. So for the normal reporting of these breast findings, so this is how we usually report it. Okay, so for the normal, above breasts are symmetric, smooth without nodules or masses, nipples without discharge, axillary adenopathy is usually included in the next section. So for abnormal findings that may suggest breast cancer, so the breasts are pendulous with diffuse fibrocystic changes with a single firm 1 by 1 cm mass, mobile and non-tender with overlying powder orange appearance in the right breast in the upper outer quadrant at the 11 o'clock position 2 cm from the nipple. So in your baits, here's also a guide on how to do your breast examination. So you can scan this QR code for you to be redirected to that video. Okay, so in your bits you have additional information, no, at the end of the chapter. So I suggest that you take time to also read that, no, so just for further learning, because you'll use that also later on as you study the diseases involved in the axilla and breast, as well as in the thorax and in the lungs. So do you have any questions so far? Because if none, then we can call it a day. No? Thank you for um, listening to the lecture, and good night, everyone.
Thank you, Doc.
Thank you so
Thank you po,
much,
Thank
Doc.
you,
Doc.
Doc.
Right, Doc. Bye.
Good night,
Thank you
Doc.
po, Doc.